Hi there. Let's talk about the Whipple procedure. We'll talk about the anatomy involved, the risks of the operation, and the expected hospital recovery. The Whipple procedure is an operation known as a pancreaticoduodenectomy, which is the surgical removal of the pancreas and part of the small bowel called the duodenum. And the duodenum gets its name from the Latin word for 12, because the duodenum is about 12 finger breadths long, or about the width of both of your hands put together. The most common reason why the Whipple procedure is performed is for removal of benign or malignant tumors of the pancreatic head or of the bile duct or anywhere in the involved area. Uncommonly, the Whipple is performed for chronic pancreatitis to remove part of the pancreas. And even more rarely, the Whipple can be performed for traumatic injury or for infection of the involved area, or if there are large ulcers in the duodenum necessitating removal. Here's the involved anatomy. Your liver is here in green and your pancreas in blue. And your liver and pancreas both help to digest the food that you eat. And they do this by making a fluid that's like dish soap or dishwasher detergent. And every time you eat, they spit some of that soap out into the gut through this red circle drawn here, which is in the duodenum. And the fluid that they make is really like soap in that it breaks down food into smaller bits and helps it be more readily absorbed by the body. And this is a pretty essential process. And without this process going on, you could still eat food, but it would not make its way into your body as well. You would not be absorbing as much of the nutrients in the food without the help of the liver and pancreas. And so the dilemma of the Whipple procedure is that in this operation, the area where the liver and the pancreas communicate with the gut is the area to be surgically removed. And so obviously you want to take the liver and the communication that's left there, and you want to take what you can of the pancreas and you want to reattach those to the gut so that digestive function can continue on as normally. And that's the goal of the reconstruction phase of the Whipple procedure. Before you get there, you have to do the resection, or you have to take out what needs to be taken out. And to do this, we generally make 4 cuts. There will be 1 cut separating the liver from the intestines, and we cut through the common bile duct to do that. There will be another cut at an appropriate spot in the pancreas, dividing it into 2 pieces. And then we cut the bowel in 2 places. We'll cut it at the stomach, and we typically fire off a stapler to do that. And it'll end up taking about 1/4 to 1/3 of the stomach in the process. And then finally, the area of bowel that has to be removed is a little downstream past where the liver and pancreas enter the gut. And so that's where the final cut is made. And this is what the reconstruction looks like. We'll pull up the remaining bowel, and I've drawn that in red here. And that bowel gets sewn to the pancreas, that organ in blue. And then that bowel gets sewn back to the bile duct. That's that green structure. And again, we do this so that these organs can continue their normal function to help you absorb food. And then later on down the line, we sew the bowel back to part of the stomach, and that's about it. Some drains will get put in if they need to be, but at that point, we're basically ready to close and finish the operation. And so you can see that the liver in green and the pancreas in blue ideally get hooked back up to the bowel. And this again aids in the absorption of food way on down the line after you've recovered from the operation. So let's now talk about some of the risks associated with the Whipple procedure. This is a very good table looking at 17,000 patients who underwent pancreatectomy. And this is persons undergoing a Whipple procedure, regardless of why they needed it. So it could have been for cancer, it could have been for pancreatitis, it could have been for trauma, etc. And this study found that the most common complication of the operation was what we call a pancreatic fistula, underlined in red. And a fistula is essentially a leak. You can think of it as a leak at the location where the pancreas is stitched onto the bowel. And this study, looking at 17,000 patients, found a pancreatic leak in 18% of them. The second most common complication is called delayed gastric emptying. And your stomach is a muscle that squeezes to help push food on down the line after you eat. And when you have had your stomach operated on, or when you have had a Whipple, even if the whole stomach is preserved, there is about a 17% chance that the stomach can be very slow to wake up after the operation. So a pancreatic leak and delayed gastric emptying, those two complications are pretty specific to the Whipple, and we'll discuss them in depth in this presentation. Other complications to know about include infection. That's a risk with any surgical procedure. And this study found about a 16% combined risk of infection, whether at the level of the skin, very shallow, or deeper inside the abdomen. There was a smaller risk of that, but if you add the two together, in green, about a 16% risk of infection. And then finally, in purple, I've highlighted some risks that are common to just about every big surgical operation. And some of those risks include pneumonia, of which this study found a 4% risk following the Whipple procedure. You could get a blood clot, and there's about a 4% risk of that too. And you could also have a heart attack or a stroke, and those are very small risks, 1% for a heart attack, 0.3% for a stroke. And certainly there are factors going into the operation that would heavily predispose you to one of those things. Although these complications happen rarely, the more severe ones in purple, they are still risks that are associated with surgery in general and with this procedure in particular. Let's talk a little bit more thoroughly about pancreatic fistula, or the pancreas leak. And the study that I just cited, actually, to mention it, this study comes from data from a 3-year period from the American College of Surgeons quality improvement database. And so the data from this table is some of the most comprehensive that's available in the entire world, I would say. But let's talk a little bit more about pancreatic leaks or fistulas. There are really 3 different outcomes that I would, triage pancreatic leaks into. Either nothing can happen, you have a leak, but it's not clinically significant. You might have a medium leak, in which the drains, you might have to leave drains in for a longer time. Some surgeons prefer to leave drains in after the procedure if they think there's going to be a risk of the leak. And the drain just goes in through your abdominal wall, and it's about the width or diameter of a drinking straw. And it's got a bulb on it that collects fluid, and you empty it out regularly. And usually these drains get taken out at about, 3 to 7 days. But if we feel that there is a risk for a leak and there's drains in place, we might want to leave them in longer, say for 2 or 3 or 4 weeks. And so if the drains are left in for a longer time, that makes it a grade B fistula. And some fistulas or pancreatic leaks are notable enough to where they require reoperation to go back into the abdomen and reattach the leaky pancreas. And if you require a reoperation, then this would automatically be called a grade C pancreatic fistula. Here is a different study. It's a systematic review of 122 different studies that involved over 10,000 Whipple operations. And this study found that grade B or C pancreatic fistulas happened at about a 14% rate. And of those two, grade Bs were more common than grade Cs. And again, remember that grade C being the one requiring another operation. So overall, if you undergo a Whipple procedure, the chance that you will need to be operated on again for a leak in the pancreas attachment is in the single digits. I would say somewhere between 5 and 7% based on what I've read. And there are some details that help us predict whether the pancreas will leak or not. But we do not know these details until we actually get into the surgery. So we will not be able to say before the operation with much certainty if we think you're at risk for developing a pancreatic leak. But during the operation, there are some things that we look at that inform us of the likelihood of a leak happening. One of those things is the texture of the pancreas itself. It can be firm or it can be soft like a stick of butter, and it can be anywhere in between. And so a softer pancreas, as you can imagine, if you stitch or throw sutures in a softer pancreas, those stitches are more likely to fall out than if the pancreas has good tissue that the needle and the stitches will stay in. And then another factor that we look at is the diameter or the width of the pancreatic duct. And you can see here that a wider pancreatic duct, greater than 0.5 centimeter, is a lower risk factor for a pancreatic leak. And that the smaller the duct gets, the greater the chance that there will be a pancreatic leak. And this is because a larger duct can simply take more sutures in it, and so it can be a better attachment. And then there's intraoperative blood loss too, but the bottom line is that we can give you an estimate of how likely it is that you develop a leak, but we cannot say this for sure until after the operation. Let's talk about delayed gastric emptying. It kind of is what it sounds like. Your stomach takes a long time to empty food out of it. And this is the second complication that's pretty particular to the Whipple procedure. And again, it happens in about 17% of patients, anywhere from 10 to 25% in any given study. And an international group got together and defined delayed gastric emptying. And it turns out that there are two criteria that are very important in making this diagnosis in the postoperative period. One of those criteria in red is your ability to tolerate a regular diet without vomiting it up. And the second criteria here in blue is based on if you need a nasogastric tube put in to go through your nose down into your stomach to suction out what's in your stomach so that you don't get big and bloated and so that you don't throw up. And so delayed gastric emptying from our eyes as clinicians is defined by whether you need that NG tube and if you can eat a regular diet. And you know, the NG tube could get placed if you are having some episodes of vomiting. We don't want you to be vomiting because that's very bad. It increases pressure within the abdomen and it puts the repairs, the different repairs that we sew together, at risk when the abdomen's under pressure like that. And symptoms of delayed gastric emptying include nausea and vomiting, like we mentioned, but also a noticeable degree of distension or bloating in your belly. And the hallmark symptom of delayed gastric emptying is fullness. Now, this can be early fullness, and that would be something like, well, I just ate and I just had 3 or 4 bites and I'm immediately full. Or it can also manifest as a late or delayed fullness, which would be something like, I ate a good-sized meal, and then 4, 5, 6 hours later, I still feel really full. And so both those types of fullness are signs of indigestion and ultimately indicate that your stomach might not be squeezing as it should. And reasons that this might happen There are many reasons. There's no one particular reason, but it is especially related to the presence of a pancreatic fistula, the leak that we just discussed. And this is because the pancreas sits right behind your stomach. And so if some of that pancreatic fluid is getting spilled, it's very irritating. And the muscle of the stomach does not like to sit in that irritating fluid, and it can have problems squeezing as a result. And then delayed gastric emptying, even in otherwise healthy people who have not had the operation, can be related to diabetes. And so if you do have diabetes going into a Whipple procedure, that is purported to be a risk factor for developing DGE afterwards. Now, there are several treatments available for delayed gastric emptying, or at least several medicines we can try. And I bring up this table just to show you we have a wide range of methods that we can employ to try to get the stomach to squeeze better if we feel that it's a little stunned after the operation. So the take home is that it's very important for you to talk to your doctor about symptoms you may be experiencing, because there are definitely therapies that can be tried to help alleviate those symptoms, but we won't know the full extent of it unless you're very talkative about it. So those are two of the big risks associated with a Whipple procedure. Now let's talk about the ideal recovery from it. Specifically in the hospital, there are some boxes that we would like to check before we can say you're safe to go home now. And that would be tolerating a regular diet, regular food, similar to whatever you were eating before the operation. And if you have to have maybe tube nutrition, then you can disregard that first statement. Another goal would be going to the bathroom appropriately without needing anything like a catheter to take home with you, although there are exceptions to that. We definitely, third, want your pain to be well controlled. We want you to be as mobile as possible, within the confines of what your body allows, whether that's standing up and walking by yourself, or whether that's walking with assistance. We want to make sure that when you go home, you have the help that you need, or you are able to get around independently. And then finally, we want to make sure that you understand how to take care of your incision and your various drains at home. And so there's a large educational component that needs to be completed before discharge. But these are the things that we have to check off the list before you're ready to leave the hospital. Let's talk about the post-operative week on a day-by-day basis. On the first day, you're not going to be eating or drinking anything. You're going to be receiving IV fluids, and you might even be receiving IV pain medicines through a patient-controlled pump that allows you to dose yourself. You will be getting anticoagulation after your operation, and that's a medicine to prevent blood clots. You will hopefully be feeling good enough to at least get out of the bed to the chair, and hopefully you can do this a couple of times in the first post-operative day. And finally, you'll also have a catheter in your bladder, and that's pretty routine, and that should get pulled pretty early on, but we want to very closely monitor the amount of fluid that you're putting out so that we can replace it as needed. That's why that will be there. We progress to day 3 or maybe 4, and that's when we want to start trialing clear liquids, water at first. There are some sorts of nutritional shakes like Boost that come in a clear form, and we'll start slow and see how you tolerate liquids on that 3rd day, maybe the 4th day after the operation. When you're drinking liquids by mouth, we'll also start trying to switch your pain medicines and all other medicines to oral forms just to get things in your gut and get it moving again. Hopefully you'll be up and walking around the hallways at this point, kind of pushing it appropriately, as much as you feel that you can, but enough so. It is very important to get out of bed and walk around to try to return to your baseline functioning as early as possible. And after you're tolerating clear liquids, if that's going well and you're not throwing anything back up and it's staying down, we might start to trial a regular diet at about day 4 or 5. So when we feel that you're checking all the boxes you need to go home, we'll start discussing discharge plans, where you're going next, whether that's back to home or maybe to a long-term care facility. And we'll start, educating you on how to take care of your wound at home and how to adjust your diet if you need to. We'll also talk about when we're going to remove the staples from the incision. And this could be as early as day 7, but a close follow-up as an outpatient coming back in to see the doctor in the clinic might be needed around day 10 or maybe as late as 14 to get those staples out of the wound. And then finally, depending on why you had the operation, but especially if you had a carcinoma of the pancreas, that's heavily related with blood clots, as well as the development of diabetes after surgery. And so we'll discuss if we feel that you need home insulin or home anticoagulation to prevent blood clots for a length of time after you get out of the hospital. So that's the expected post-operative recovery from a Whipple procedure. We talked about 2 of the big risks of procedure being a pancreatic leak and delayed gastric emptying, and those affect about 1 in 6 to 1 in 5 patients who undergo this operation. We talked about other complications that can occur, including infections, blood clots, and very rarely heart attacks and strokes. And we discussed the anatomy of the operation, what gets removed, and how the repair is made. So I hope that you found this video very informative. Thank you for your time.